Shine a light on your research by presenting your work at RSNA 2024. We are looking for thought leaders to provide scientific presentations, education exhibits, and quality improvement reports. Submissions are open February 21st through May 1st, noon Central Time. Submit your abstracts today. Go to rsna.org/abstracts.
Hello, everyone. Welcome to the RSNA RadioGraphics podcast. My name is Sarah Bastawrous, and I'm an abdominal imaging radiologist from Seattle, Washington. This week on the podcast, I will discuss the recent article titled Multimodality Imaging in Metabolic Syndrome, State-of-the-Art Review, by authors Kevin Kalisz, Patrick Navin, Malaka Tani, Amit Agarwal, Sudhakar Venkatesh, and Prabhakar Rajia. The authors provide an excellent and comprehensive review of the multimodality imaging-based features associated with metabolic syndrome. Now, full disclosure here. When I think of metabolic syndrome, I didn't realize that it has significant global health impacts due to its association with cardiovascular disease, diabetes, stroke, and obesity, and as radiologists, we can play an active role in the diagnosis. So, what is metabolic syndrome? Well, it's a group of risk factors associated with the development of cardiovascular disease and type 2 diabetes. It is multisystemic and can involve cardiovascular, musculoskeletal, hepatic, pancreatic, renal, GI, gynecologic, and neurologic systems. And its prevalence is increasing across the world. Imaging modalities can help assess metabolic syndrome and its effects on target organs. These risk factors affect patients who are overweight and include dyslipidemia, hypertension, and glucose intolerance. Perhaps of greatest clinical concern are the increased risks for diabetes and premature cardiovascular disease. The diagnosis of metabolic syndrome is made when at least 3 of these 5 criteria are present: abdominal obesity, impaired glucose tolerance, hypertriglyceridemia, low high-density lipoprotein levels, and high blood pressure. So why is metabolic syndrome an important health concern? Well, about 20 to 25% of the worldwide adult population has metabolic syndrome, and its prevalence in the U.S. is increasing. Addressing these risk factors early can help prevent or delay the onset of conditions like heart disease, stroke, and type 2 diabetes, leading to better health outcomes and improved quality of life. The authors in this article begin by discussing the imaging modalities in assessment of metabolic syndrome. Table 2 in the article provides a great summary of each modality and its application in the evaluation of metabolic syndrome. Briefly, ultrasound can quantify fat in several compartments, although it is limited. CT shows excellent delineation of fat and high-resolution assessment of vascular plaques and stenosis. MRI provides superior soft tissue characterization and fat quantification, and there are standard techniques in the assessment of the liver, heart, and brain. Nuclear medicine techniques provide physiologic information on risk factors and end organ injury in the heart, kidneys, and brain. So what are some ways metabolic syndrome risk assessment can be done with imaging? Well, one is the quantitative measurement of the volume and distribution of adipose tissue, which is an important biomarker for diagnosis. First, a little background on fat. Adipose tissue is a dynamic endocrine organ and is broadly classified as white adipose tissue and brown adipose tissue. The primary function of white adipose tissue is energy storage and is subdivided into 4 groups: subcutaneous adipose tissue, which is below the skin and contributes to cushioning and insulation; visceral adipose tissue, which lines the internal organs; bone marrow fat; and perivascular fat. It's important to note that visceral adipose tissue is thought to play a larger role than subcutaneous adipose tissue in the pro-inflammatory state and insulin resistance of metabolic syndrome, and is associated with dyslipidemia, hyperinsulinemia, and glucose intolerance. The quantitative measurement of volume and distribution of adipose tissue is an important biomarker for metabolic syndrome. CT and MRI provide excellent anatomic differentiation of the body compartments and can provide a volumetric assessment of fat. Dual energy X-ray can provide total estimates of body fat percentage and segmental fat within the extremities and is a low radiation, cost-effective, and whole body alternative to CT and MRI. Another way is quantification of ectopic fat, as increased fat around certain organs is associated with metabolic syndrome risk factors. Perirenal fat thickness has been most studied, and it's shown that increased perirenal fat is associated with hypertension, cardiovascular disease risk factors, and renal dysfunction in diabetes. CT and MRI are the best modalities to quantify total perirenal fat. Figure 4 in the article nicely demonstrates the anatomy of renal fat layers. Now, in the heart, pericardial fat is the epicardial fat layer between the outer myocardium and visceral pericardium and is metabolically active, producing free fatty acids and inflammatory mediators. Pericardial fat measurements at CT and MRI have been linked to metabolic syndrome risk factors. Increased pericardial fat volume is also associated with coronary artery calcifications, diastolic dysfunction, and decreased cardiac output. This article also discusses perivascular adipose tissue as other sites of ectopic fat and their association with metabolic syndrome risk factors. Now let's discuss target organ injury in metabolic syndrome and how imaging can identify early development and progression of its impact on certain organs. Table 3 in the article goes through the major organs and highlights the metabolic syndrome complications and role of imaging, and I think this table is a great reference to keep handy. I'll briefly discuss cardiac and liver complications here. For the cardiac system, the authors provide the teaching point that cardiac complications of metabolic syndrome range from a subclinical state progressing to a symptomatic state and eventually to an irreversible state manifested by myocardial infarction, heart failure, and arrhythmias. Cardiac manifestations of metabolic syndrome can lead to structural and functional changes and coronary atherosclerosis. Subclinical coronary artery disease can be screened with gated non-contrast CT to quantify coronary artery calcification burden. Coronary CTA can identify high-risk, non-calcific plaque, which are prone to rupture and more common in metabolic syndrome. PET imaging in patients with metabolic syndrome can identify perfusion defects and ischemic myocardium. MRI can provide high spatial resolution assessment of myocardial viability, where late gadolinium enhancement, more than 50% of the thickness of the myocardium, is used as the threshold for non-viable myocardium. Now, in the liver, non-alcoholic fatty liver disease, or NAFLD, and metabolic syndrome are closely linked and share risk factors such as insulin resistance, which increases storage of fat in liver cells. NAFLD is the excessive accumulation of fat in the liver and the absence of alcohol consumption and other causes of chronic liver disease. With metabolic syndrome on the rise, NAFLD has become the most common cause of chronic liver disease, the second leading cause of liver transplantation, and the fastest growing cause of hepatocellular carcinoma. Liver ultrasound can identify hepatic steatosis very well. On grayscale ultrasound, steatosis appears as increased hepatic echogenicity and has 85 to 87% sensitivity and 80 to 94% specificity for diagnosing fatty liver. Controlled attenuation parameter is a quantitative ultrasound-based tool of attenuation through the liver in decibels per meter and provides rapid point-of-care assessment for mild steatosis and for steatosis with advanced fibrosis. Non-contrast CT can also suggest steatosis when liver attenuation is lower than that of the spleen or hepatic vasculature. MRI can provide qualitative or quantitative assessment of hepatic steatosis and is superior to ultrasound and CT. Qualitative methods include increased signal intensity with fat-only Dixon imaging and decreased signal intensity with fat-suppressed sequences compared to without fat suppression sequences. Quantitative methods include a drop in liver signal with a post-phase versus in-phased sequences, and PDFF measured on fat fraction maps from chemical shift encoded MRI. The article provides excellent corresponding figures demonstrating these techniques. Metabolic syndrome also has effects on the pancreas, kidney, GI tract, musculoskeletal system, breast parenchyma, and the brain, which are discussed in detail in the article. In conclusion, metabolic syndrome has significant global health impacts due to its association with cardiovascular disease, type 2 diabetes, stroke, and the obesity epidemic. Information obtained at imaging can provide an objective assessment of components of metabolic syndrome, such as fat quantification, and help identify early changes or damage in target organs. Radiologists should be aware that multimodality imaging plays a role in metabolic syndrome and that CT and MRI are the primary tools for quantification of excess fat, including subcutaneous and visceral adipose tissue, as well as fat around organs. I really hope you enjoyed this RSNA RadioGraphics podcast episode. Please make sure to check out the full article and the wonderful figures, tables, and movies that it has to offer. Thank you so much for joining me.